Perfect. So, my first question is, what do you say? How serious is the problem of bias in clinical trials and studies?
I think that there's a serious problem with bias in clinical trials. It has been a problem for a long time. Some of these biases arise because of conflicts of sponsors who would prefer to get a particular type of result. Others are related to the methods that are suboptimal and often lead to misleading conclusions. And sometimes there is an interaction of these two. We have bias studies that on purpose try to get results that would be favorable to sponsors.
What kind of bias are there? How to find them?
I think there's a very long list of biases. One of my mentors, the late David Sackett, had cataloged more than 100 different biases that could affect clinical research. And the list has grown longer since then. So it's not one or two things that can go wrong, but multiple processes. Uh, the the major ones might be related to the choice of the design and the choice of the question to ask. Sometimes the question is asked in a way that the answer, even if the study is done correctly, is going to be perhaps misleading. For example, if you compare a new treatment versus a Stroman comparator, you may find that the new treatment is better, but it is better than something that is worse than nothing. uh, then you have problems in the ability of the study to study the question. For example, many of the studies are very small, and many of the studies have measurements that are very inaccurate. They depend on tools that are not very well validated, or they have a lot of subjectivity. Some of the outcomes may be very susceptible to biases because of lack of blinding. People would know what they have been assigned to, and their responses may be dictated by what they have been assigned to. Some very fundamental flaws in the design of randomized trials might be lack of allocation concealment when you have randomization, but people can tell ahead of time what the next patient is going to be randomized to. So in a way, you can cherry pick the participants who go into either of the two compared arms, despite the fact that supposedly the trial is randomized, and many, many more. And then there's problems in the analysis, many problems in the reporting. Unless you follow exactly your original plan of what you aimed to study and what you aimed to present at the end of the trial, people may change their outcomes. They may add new outcomes. They may drop some of the outcomes. They may modify some of the outcomes. And this leads to a lot of degrees of freedom in presenting results that may be more congruent with one particular narrative, or suppress some of the evidence that is not very favorable. At the end of the day, you have the extra layer of dissemination. You know, what is going to be published? How is it going to be published? How is it going to be disseminated? Well, what will be in press releases? What will be in the media? What will science journalists write about the studies in conjunction with the investigators? How would sponsors promote the messaging about the particular clinical study? So you have many levels that things could go wrong, and some of these biases could be multiplicative. They could have an effect that gets distorted further and further as we move down the path from thinking about what question to ask all the way to getting a result and disseminating it.
Is it even possible to create a study without bias?
Well, this is asymptotic perfection. We wish to design studies that have no bias, and I think that any researcher is struggling to do this. Well-intentioned researchers, their goal is to design studies that have no bias. But we always have some problems, small problems, mid-sized problems, large problems. We try to think of those in advance, and we try to prevent them, or we try to think of ways to correct them if they arise. So there are many studies that are really very good, very strong, and have minimal bias. and that I would put more trust in them compared to some studies that have overt biases. It's always a struggle. I'm not sure that I can say that there's the perfect ideal study which is 100% perfect in all regards, but there are many studies that are very good. I don't want us to paint a completely pessimistic view that doing a very good study is impossible. It is possible, it does happen, and there's many such out of the millions of studies that are out there, of course.
How many studies you would say in the clinical topic are good and without bias, or how many studies are bad and have bias?
That's a tough question to put specific numbers into because it depends on what biases we're talking about and how serious are in terms of their impact. If we focus specifically on randomized controlled trials, I would say that probably there's about 10% of them that are pretty well done. They're informative, and that probably you can put quite a lot of trust in them. Then the other 90% you have to split into different bins, some of them being completely unreliable, biased, a small percentage, well, small, perhaps even up to 5% might be even fake. And then you have those that are very biased, that are probably about 50%, and those who have substantial flaws, and they may be about a third of the total. That's a very rough breakdown of what we're dealing with at the moment.
Are we talking now about studies in general or specific about the clinical studies?
For clinical studies, in particular randomized controlled trials. And I think that if we go to more broadly, any type of clinical study, the rates would be worse. I think that the biases would be worse because randomized trials, in a way, you have to think more about the design. You need to pass through more quality checks, sometimes even regulatory checks. If we go more broadly for any type of study, then probably that would be even worse than than that, because there's far less control, far less regulation, far less oversight, and also often less training or less attention to problems of bias for various reasons. Some of them related to conflicts, and others just related to researchers making choices that are suboptimal in how they design and implement a study.
So the pharmaceutical studies are typically, in general, better than the others.
I wouldn't say specifically pharmaceutical, because randomized trials can be done with different types of interventions. Some of them may be drugs, others may be even psychological interventions, behavioral interventions, things that we try to intervene to change some outcome. So in principle, randomized controlled trials, other things being equal, probably would be better than other designs. But this cannot be applied to every single randomized trial being better than the equivalent non-randomized. Just like an average, that randomized trials, if you can have a randomized trial, I think it's better than having something else.
But also in randomized and double-blinded studies, there can be bias. How?
So all of these things that I mentioned can happen in randomized trials. And even in double-blind studies, you can get most of these biases still. I mean, you can still ask the wrong question, have the wrong comparison, a suboptimal comparison. You can still have uh, outcomes that are not very meaningful, that have a lot of leeway for measurement error, that you can have an analysis that is flawed, that you can mess up with missing data, with how you report the results, or how you distort outcomes eventually, or how the message is being disseminated. So double blinding is, let's say, an extra safeguard to some extent, that may help diminish some types of biases, but not all. And most biases could still interfere even in a double-blind study. In fact, double blinding comes with some cost, not financial, but cost in terms of the validity of the study. For example, if you think about double blinding is not something that happens in everyday life when people are using a new medication or are getting some intervention. So in a way, double blinding is creating an artificial environment, artificial conditions that do not reflect real life. So double blinding diminishes the pragmatic relevance of the trial. It makes it less relevant to what you see in everyday clinical practice. And this is a price that we are often very willing to pay because we feel that double blinding will somehow alleviate or decrease the chances of other biases interfering. Because if done correctly, those who provide the intervention and those who get the intervention do not know what intervention they have received, and therefore maybe some of the biases is removed. But nothing is perfect. It's just one step that is mostly beneficial, but also has some collateral disadvantages.
The bias can also happen before the study is beginning, talking about design, but also screening the groups of placebo, but also the verum group. And you can make a study before and look which kind of people are yeah, sensitive to the placebo effect, and then screen them out and so on and so on. How to handle with this, and how yeah, how serious is this kind of bias?
So there are biases that are related to the selection of the study population. And many studies, by their design, may select populations that are not representative of what is happening in the community. They may not represent the general population or the population where an intervention is going to be used eventually. Or they may even be filtered to be people who respond very well, or people who do not have adverse events. For example, some studies have some initial periods where uh, you can select those who tolerate the drug in a way, and those who do not have adverse events, or those who seem to have some initial response. And therefore, you have already selected like the best case scenario. And the best case scenario may not be possible to transfer to the average patient who would be in the community and wants to consider taking that drug. Uh, we do have a problem in most randomized trials in terms of their external validity, meaning how do they translate for the average patient. Most of the clinical trials select populations that are not representative of the average patient. They're circumscribed. They often exclude people who have comorbidities, people who are sick, people who are not doing well, people who are not in good enough condition. And these might be actually the cases where you really want to know whether that intervention is going to make a difference. And this is where you may get most trouble when that intervention gets used by real patients. So randomized trials are always facing that dilemma. Do I try to get a very clean sample, which may not reflect what is going on in the real world? Or do I try to approach as much the real world, have what we call a pragmatic design, try to get everyone on board, and then see what happens? But obviously, that will be a pretty messy population because lots of things can go wrong with these people, and that's always a tension in what end of this spectrum between pragmatism versus a very exploratory, experimental, artificial design one wants to go for.
um, about the age and the health condition you can find in this design of the studies, if it's a good study. But what about yeah, some difficult questions like a pre-study filtering out even the people who are, yeah, who react on a placebo effect. How you can find these people, if they are in or not, if it's a pre-study. Is there any law to make a registration about the study to make it transparent?
For many years now, registration has been adopted as a requirement, at least by major regulatory agencies and also by most of the medical journals, especially top journals, routinely would ask for registration. Now, registration practically means that you post your intention to run the study along with some aspects of the design. Usually, these registration websites have a form that one needs to complete. Very often, it's not even the investigator, but some administrator who fills in the data, not necessarily very accurately so. And therefore, everyone knows that the study is happening and this is what it is about. And hopefully, this is how it is going to be done and what the outcomes are going to be. So that information may or may not be complete. It may or may not be accurate. It may or may not be detailed enough to know exactly what will happen, because if it's not detailed enough, then there's still many degrees of freedom, many opportunities to deviate and to do different things compared to what one had in mind. Still, there's many trials that are not registered at all. Probably around the world, it could be even half of the trials are not registered. And even among those that are registered, the information is not detailed enough. So in many cases, one can very easily deviate from the plan, and that would not be noticed. A smaller proportion of trials have very detailed protocols that are posted and are posted in public before the study is run so that one can compare notes between what was promised and what was done. When we do that, we see that very often there's deviations. People have deviated, for example, in the outcomes that they intended to study versus what they report. And an even smaller percentage, probably in the range of maybe 2%, have detailed statistical analysis plans, which means that it's not only that you have a protocol, but you also have the explicit statistical sequence of analysis that are going to be run. And then you have a very accurate footprint of how exactly the data sets are going to be collected and analyzed and with what exact statistical model and what is the exact process. So then you can really have a very good grasp of what was the plan and whether it was implemented or not. But this is happening in a small minority of clinical trials. So there's a lot of ways that people can deviate and can change their plans, and no one would know, or sometimes we would know if we were to look, but they still do it. Many journals actually are asking for registration in order to publish the reports. And what we see is that many trialists post a registration after they have finished the trial, just for the sake of being able to publish their paper in a journal, which, of course, a registration after the fact, after the study is being done, is a little bit like a ritual. It's not really serving the purpose of informing people that the study is done, it will be done, it has been done in that case, and this is how it's going to be done. Again, it has been completed. So it is more like a ritual that is even misleading because people think, oh, so that was a registered trial. Well, in fact, it was not registered. People were just told, well, create a registry record, even though you have finished the trial already.
Is there any registration about this pre-studies and about this filtering process, which is yeah, probably not even in the study design?
Yeah, ideally there should be, but some of these earlier deliberations perhaps would not be visible. So we don't know, even when we see a registration record, whether it contains all the steps from the very inception of the idea until getting to the point of seeing the official study in a way in the registry. And we do know that sponsors may try different approaches, and they may do lots of piloting. the registration of piloting in principle is even less complete than the registration of the uh, trials themselves, let's say the main trials themselves. That can add extra levels of misleading information because you don't know how people got there. So you're seeing a starting point that is not necessarily the real starting point. It's 5 steps after the process has started, and that could be a problem. It could be a problem more in some situations compared to others. But as I said, we have a problem even with registering the main trials, let alone the early exploration steps or filtering steps that very often are not visible at all.
Visible, that's the key word. It's very complicated to read a study and understand it because detecting the bias which are in there is more easy, but not easy, but more easy to then detect the things that are not in there. How can you find this bias or these factors who are not in the study?
Uh, Most of the time, it is impossible. It is like detective work, and you need to become a sleuth and devote your career to trying to unearth non-visible information. And you become paranoid at times as you realize, thinking that there's things that are not visible. And It's not easy. And this is why I think that the scientific community for many years now has moved in the direction of asking for more transparency, making sure that we have less of the non-visible component. I don't want to be a pessimist and a nihilist. We have seen improvement. The registration rates are improving. Registration records on average tend to be more complete. We have more full protocols. We have more statistical analysis plans. So it's not that nothing is moving. We have seen improvement, but still, in the majority of trials, there's a lot of things that are not visible, and that leaves more room for some skepticism about single trials. It also explains perhaps why some results of these trials are so weird. At face value, they seem to be performed pretty decently, but the results are very weird. And perhaps if we could see some of that non-visible component, we would understand why they're so weird looking and so extreme and so unrealistic. Um, it's not a done deal. I think that we need to push more for more transparency and try to unearth more of that invisible part. And until then, we're left with lots of unexplained situations and lots of surprise results and lots of results that um, don't make much sense or are entirely incompatible with what we knew, or sometimes they form the basis of recommendations that are very shaky, or they should be, but we don't know why exactly something is wrong.
Do we need more sanctions? For example, since 2016, pharmaceutical companies in the European Union have also had to enter the negative results in the study register, but there are no sanctions. So, how many actually do that?
I think that this is a big debate. Regulators have asked for the results of trials to become available, especially trials that have been included in the regulatory packaging of the review of applications for drugs and biologics and vaccines. And there are sanctions both in the EU and in the US for not doing this. Um, they're hardly ever implemented, though. And there's that debate on whether we're shooting ourselves in the leg by not really enforcing the laws that are out there, the regulations that are out there. If we were to do this, probably many companies would have to pay enormous amount of money because they have delayed the availability of results for a very long time. And as you realize, it becomes kind of a political game on whether these sanctions would be implemented or not. If you have regulations that are not implemented, then probably people will not respect them. I think that that's widely known. It goes beyond clinical trials. So if we think that these regulations and sanctions are out of proportion, perhaps we should revise them to make them more proportionate. But I think that they should be implemented because otherwise we're just giving a signal that we don't care. That yes, we tell you to do so, but if you don't, you're not going to be caught, and nobody would bother. And I don't think that this is a good signal to give.
How big is the problem of the conflict of interest that the pharmaceutical companies, yeah, designing and financing their own studies?
I think it is a huge problem. It is a bit like having a painting competition and the painters judging their own paintings on who will get the first prize. And it has been accepted somehow over the years that this is the way that it should be. And the reason is that public funders have said that, well, we don't have money to give for this type of trials. Let the companies pay for them. It's their own products, and they will make money when their drugs and biologics and vaccines get approved. So there is some logic behind it, but I think it's the wrong type of logic. My preference would be for companies to pay mostly for the research that leads to the development of these new pharmaceuticals, biologics, and vaccines. They have every reason to pay for this type of research because they really want to develop the best products. So they will have an incentive to really get the most effective interventions developed. Most of that phase is currently funded by public funds. So it is, in the United States, NIH is paying for most of that translational phase where you try to develop some new discovery into something that would be possible to test, and to some extent by startups. But I think that, it should be entirely entrepreneurs who should do that. And I would argue that when it comes to testing the developed intervention, you have a drug now and you want to test it whether it is effective in real patients and whether it should take a place in how we treat that disease. I think that public agencies should do these trials, and they should decide what is the best design, what is the real question, what are the best comparators. There would be no reason to bias the results if they're only thinking about the public good. So that would save a lot of money from public funders. It would also save money from the company because there's a lot of inefficiency currently. There's just lots of research that is done in a way that is not very efficient and not asking the really important questions, and just lots of small studies here and there and studies that lead nowhere. I think it would save money. It would increase reliability. It would increase trust in the evidence. If we continue the way that we are now, practically we still have companies designing their own trials to bless their products. So they will try to do their best to get favorable results. They will do their best to try to satisfy people like me or other methodologists who are looking for biases. So they will look at oh, here's a checklist that John Ioannidis and others have developed of 10 biases. Let me see if I can just check these 10 items, at least superficially, to make people who are bias hunters happy. But still, there's so many other biases and so many other things that can go wrong that it can still go wrong. Starting from the very fundamental, like, what is the question you're asking? Maybe everything is done perfectly, but the wrong question is being asked. And unless we dissociate funders from their own products, I don't think we will get that.
What do you say about the performance, but also about the transparency of the FDA and also in Europe, the European Medicine Agency? And for example, one director from the FDA now works for Pfizer. So what do
Yeah.
you say about this?
There's a big problem with what we call the revolving door phenomenon, and regulators very often they move on to jobs in industry, specifically the industry that they have previously regulated, very recently regulated. And you mentioned one example. There's many such. About 10% turnover is what we see in the FDA. So every year, about 10% of the FDA workforce moves on to other jobs, and usually it is the industry, and usually it is the industry that they have regulated. And it makes some sense because they know the job, they know the field. But if you're thinking that you're working on a job and you have to satisfy your future employer, that's not going to be a way to secure that you're objective and unbiased. Even worse, FDA practically is funded by the industry. So not only the future employer, but FDA people feel that they're employed in a way by big pharma. Not directly, they're employed by the federal government, but much of the funding for FDA comes through big pharma, and it comes through programs that have performance bonuses. So if you can get applications approved and drugs licensed faster, that will give you more money. So your incentive structure is such that you want to get these drugs approved as quickly as possible, and then your agency will get more money. Then you will get perhaps the same salary, or perhaps it will be higher, but your agency in general will be more robust financially, and you will not be so stressed out, and probably you would feel more secure. So this is a very perverse incentive system. We have not managed to keep regulators from industry separate. They're a very intermingling type of communities. And obviously, trying to keep them at an arm's length would be important. And I think that we could do that. We could say that if you're a regulator, you cannot go into an industry job. Now, that may decrease perhaps the attractiveness of getting a regulator job, but perhaps also it would lead to a different phenotype of people who seek to go into this type of employment. Perhaps we'll get people who would be less biased and people who are understanding that this is what they do, rather than see that as a stepping stone for moving to an industry career.
Is it possible that you log in under the same link again? And because I have some questions to you, is it possible for you?
Yes,
Perfect.
of
Thank you
course.
so much.